So I really appreciate following Dr. Tuttle, and it's always nice to hear my colleagues speak as well. I am lucky in the sense, to some degree, however you look at it, that all of my patients who see me have cancer. So there's not this ambiguity of, is it cancer, is it not cancer? They have cancer by the time they see me. So a lot of this will be a little bit different in terms of how we're approaching these patients. Just a couple of my objectives here. They're in the agenda as well. We're going to be talking about the mutational landscape of thyroid cancer, systemic therapies that we have to offer for our patients with those mutations or molecular aberrations, and then an important note on toxicities, because that's a lot that I deal with. Again, all of my patients have cancer. More specifically, when it comes to my thyroid cancer patients, I would say all of my patients have thyroid cancer that is incurable, and a fair amount of those patients of mine will ultimately succumb from their disease, to put it in perspective. So just like Dr. Tuttle had mentioned, we don't always have to treat. We can have oncologic surveillance or observation. We don't have to do something active necessarily. That is also true when I see patients, and ideally I see patients before they need to think about systemic therapy. It doesn't always happen, but establishing that therapeutic alliance is what I call, serves the patients really well to sort of gain my trust and to establish also the trajectory of what their disease is going to do. But my very first thyroid cancer talk that I gave when I was a fellow over 10 years ago now included this slide, and I always keep it to start off because especially 10 years ago, this was how we approached advanced thyroid cancer. You have surgery, and then radioactive iodine, and then some more surgery, radioiodine, maybe some radiation thrown in there, and again, and only way down the road we're kicking the can to give any systemic therapy. And a large reason why that was 10 years ago, we really didn't have much. In fact, in 2013, 2014, you'll see in a couple of slides, we really had nothing. So I was constantly just being taught to know when to refer, again, the location, the anatomic location, the size, all of those 5 important key features that Dr. Tuttle had mentioned to basically get our patients back to the provider that could help them, and it wasn't us. Though this data is pre-molecular targeted therapy era, I still keep this in the back of my mind that patients with radioactive iodine refractory differentiated thyroid cancer have about a 10% 10-year survival rate. That keeps it in perspective for me and for my patients. When I meet them, am I meeting a 68-year-old or a 38-year-old? It's going to be a little bit different in what my overall outlook looks for them. And survival is 2.5 to 3.5 years for patients with distant metastatic disease. Again, I would like to think this isn't true for patients who harbor some of these targetable oncologic drivers, but this is data that we have. So we don't give all of the radioactive iodine that we used to, or hopefully we don't. And one of the reasons is because of toxicity, at least in patients who don't need radioactive iodine. This was a publication from our institution. Mainly, 90% of the authors there are hematologists within our group. To investigate the risk and outcomes of secondary hematologic malignancies in patients with well-differentiated thyroid cancer treated versus not treated with RAI. And it found striking results that there was an increase in early risk of both acute myelogenous leukemia and chronic myelogenous leukemia. And so the authors concluded we shouldn't just be using this willy-nilly. We need to have some guidelines and some justification to do this. It's not, a treatment free of toxicity. AML, CML are not great diseases to have. When it's caused by another treatment or treatment-related AML, it's exquisitely difficult to treat and almost universally fatal. So prior to 2013, so I was a fellow in 2013, around this time, the only FDA-approved drug was something called the Red Devil. We still call it the Red Devil today. It's doxorubicin, adriamycin, because it's red, and when it drips through the IV, and it causes a lot of side effects. It also doesn't work very well or at all for thyroid cancer, but in 1974, having an experience with 30 patients using this drug will get you a New England Journal of Medicine publication. So it's really difficult to see, but papillary, spindle, medullary, Hürthle cell, unclassified, these were all comers of thyroid cancer treated here. Thankfully, we don't do that anymore. I've treated one patient in my entire career with adriamycin. It was an anaplastic patient. It did not go well as expected. We know because thyroid cancer doesn't respond to cytotoxic chemotherapy. We need to target the cell cycle and various parts of the cell cycle, and that's where we're identifying molecular drivers, molecular aberrations, fusion proteins, things that we can develop a drug and target exactly within the cell cycle to treat patients with thyroid cancer. So specifically, mutational testing. So it's so important that a group of experts came together to develop these guidelines. Dr. Tuttle was one of those experts. And it was really a joint collaboration with AHNS Endocrine Surgery Section as well as ITOG to develop this consensus statement. Consensus statement is always misleading because it's not. It's like a thick document that is pretty dense and you have to go through. But if you have a chance to look at this, what I didn't include here are the elegant ways to define what advanced thyroid cancer is. What does it look like? What are the characteristics does it have? If your patients fall into this, they really need to consider multidisciplinary care and treatment. But it has included within it 20 statements regarding the diagnosis, the management, how do you treat these patients, affirmations of what to do to best care for these patients. And I'm going to sprinkle some of these statements throughout my talk today. Starting with statement number 11. And I think this goes to just, again, the baseline of what we've been doing as medical oncologists treating advanced thyroid cancer with multi-kinase inhibitors. Such as lenvatinib should be offered for the treatment of patients with progressive or symptomatic differentiated thyroid cancer that has failed conventional therapeutic options. Now, a side note, I have underlined here progressive or symptomatic. I can create an entire 30 to 60-minute talk about what that means. Again, I want to see patients sooner than when I need to start these treatments to establish that therapeutic alliance. So it's most of the time I will meet a patient for the first time and say, acknowledge all of the treatment and the history and the course and the follow-up that you have had till you get to my clinic and meeting with me. I'm not going to do nothing, but I'm going to get repeat scans. We're not jumping to the medicine cabinet to provide any pills or infusions or anything to actively treat your cancer. We're going to continue to watch it closely as we command the ship together. So the early studies, this is the decision trial looking at sorafenib and radioactive iodine refractory cancer. It's a phase 3 study. When you design phase 3 studies, you're designing the investigational arm with the drug that you want to study and comparing it to the control or what the standard of care is. You'll notice at this time there are no standards of care because there wasn't. So sorafenib versus placebo, the objective response rate was 12%. In the cancer world, when we talk about objective response rate, we mean what is the tumor doing? Is it actually shrinking? Clinical benefit, when we talk about clinical benefit, we're talking about not just tumor shrinking down, but also not growing or spreading. So that's called stable disease. But when we're looking at designing clinical trials, we want drugs that work. And by work, we mean shrinking tumors down. So with sorafenib, the objective response rate is only 12%. That's not great, which means we have to be a little bit more proactive, a little bit more clairvoyant. When are they going to develop symptoms from their tumor burden? Because I need to intervene before that happens, because at best, with this drug, I'm going to get stable disease. It's unlikely that their tumors are going to shrink. That was the first drug that was approved. Then a couple of years later, the SELECT study was published, and this is lenvatinib. Lenvatinib has multiple targets or areas, different proteins, different parts in the cell cycle that it targets, which are listed here. That's good because on one hand, it means it can work pretty well, and it does. This study showed, again, placebo-controlled because this study started before sorafenib was approved. However, about a quarter of patients had prior oral therapy, whether it's sorafenib or pazopanib, any of those other multi-kinase inhibitors. The overall response rate, much better, 65%. This was the 2-year update of a couple of years after that. And so what we keep in the back of our mind is that if these patients respond, again, meaning their tumors actively shrink down, you have a tumor here, you give drug, you don't see it anymore, or it has shrunk down immensely, we know that on average, that response with this medicine is going to last for about 3 years or more. For non-responders, even if they have good scans, meaning you halt the progression or the growth of the disease, much less. So again, it matters what those scans are showing. And this is an example of that. So this is a patient we treated, progressive pulmonary metastatic disease. He was previously treated with sorafenib for a couple of years, stable disease at best, was off treatment for 2 years because of toxicities. That would beg the question, did he really need to be on it in the first place? But then presented with worsening dyspnea and new oxygen requirement, and he was started on lenvatinib, 14 milligrams daily. Another side note, I can also go into a completely separate talk about what doses you use, and there's some controversy with that, whether you start high and taper low, start in the middle, and kind of play around with it. I'm happy to talk offline. Maybe it'll come up in the case discussion, I'm not sure. But these were his baseline scans. And then after 2 months of being on lenvatinib, you can see a clear improvement. And he felt better, was off of oxygen. We continued the lenvatinib, didn't go up on the dose at all because he was tolerating it okay, but ultimately he drove a treatment break due to ongoing chronic treatment-related toxicities, had stable disease on the imaging after that initial, partial response. This was a quality of life assessment. Again, I'm not curing these patients with these medicines. So when we start these medicines, it really is a balance between treating the cancer and balancing the toxicity profile or the side effects that you get from it. If the goal was to cure the cancer, we can justify more toxicities than if we can't. So patient was back to his baseline, felt fine, but then a few months later noticed his pulse ox was dropping, needed oxygen again, so we resumed the lenvatinib. Within a month, he was off the oxygen and doing well. So what did this case show? Number one, excellent response rates to this drug, this multi-kinase inhibitor, lenvatinib. The duration of response is on a measure of years, potentially, which is a promising thing in the world of metastatic incurable cancer. And we demonstrated the ability to resume treatment following a break. So what's the problem here? Well, the problem is toxicity. And before you read the points on this slide about impaired wound healing, which I'll get to in a moment, almost everybody experiences some side effects with these medicines. So it's really difficult to justify taking someone who has metastatic disease that we can see and measure on a scan, but they feel fine. And this happens so many times with thyroid cancer because, as you all know, thyroid cancer loves to go to the lungs. And then it can go to the lungs and just kind of hang out for a while. And I show patients their scans all of the time, and I point out exactly the nodules of cancer there so they know what I'm looking at and what I'm thinking of and seeing. And what I tell patients is, your lungs are very large organs, and they're very forgiving. So you can actually have a lot of cancer and be completely asymptomatic. And most of these patients are asymptomatic. So if it's really hard to say you are doing fine. If we didn't take pictures or scans, you would never know that you would have cancer. Here, take this pill every day where at best you're going to feel like you have a low-grade viral illness or the flu every day that you're taking this medicine for the sake of making your pictures look better. Again, there's some argument and controversies of whether starting sooner rather than later when they develop symptoms, and we can get into that if there's specific questions about it. But these are some of the things that we work through on a day-to-day basis with patients. Lenvatinib in particular will cause hypertension in a lot of patients. They're often needing 2, 3, or 4 different antihypertensive medications to bring the blood pressure into an acceptable measure of control. I have had 2 patients now who have had history of diverticulitis who, while on lenvatinib, have had acute bowel perforations because of the effects that it can have. So it's very dangerous drugs, and especially when it comes to impaired wound healing. So as soon as I start a patient on a drug like this, I'm very adamant that they understand if you ever need to have surgery for anything, if you need to go to the dentist for anything other than a simple cleaning, I want to know about it because I want to know what that procedure is. I want to guide you on how long to hold the medication before and after whatever that procedure is. And one of the major reasons is because of this impaired wound healing. 2% reported among clinical trials. Lots of reasons why this can happen. And it really poses a problem for these side effects where if the medicine's working and the cancer's good, but it's causing some problems where we have to stop it, I don't have a lot of other treatment options to offer, unlike breast cancer or some other hematologic malignancies. So it's not that easy of an answer. Consider this, anybody's warning, we just had lunch, so it's not before lunch, but if you need to look away, there's a couple of photos that can make you uneasy if you're not used to this. Again, I'm a head and neck oncologist, so this is sort of like my world all the time. Okay, so this is a patient. These are pictures when I first met him. So he rolled into my clinic, and this is what he looked like when he took all the bandages off. So he was a patient who had a really pretty rapidly, from the very beginning, aggressive thyroid cancer. It was all limited to the neck. He had no distant metastatic disease at all. It was sort of behaving like anaplastic, but we reviewed all the pathology here. There was no anaplastic in it at all. And he had a good surgery. He was planned for radioactive iodine, but before he could even get there, he was having evidence that tumors were growing back, whether it was refractory disease, persistent disease, recurrent disease, I don't know. And so his local oncologist, always that, Dr. Tuttle, always the outside oncologist, right? But they did a great job. They started him on lenvatinib straight away, which was wonderful, got things well under control. But what started as two almost pinpoint little, right along the surgical scars, where none of us would think anything of it, slowly and progressively grew into this. Where he was, they tried to put a wound vac on. They tried to stop the lenvatinib. Every time they stopped, he was near asphyxiation because he just had this very odd, this is not normal, but just very odd, almost like paradoxical effect when you stopped the TKI, where disease just progressed really rapidly. And so he actually came to get into a clinical trial that we had offered because of a particular molecular aberration that he had. This was papillary thyroid cancer, but he harbored a RET fusion. And so he was wanting to get on to the LOXO clinical trial that we had open here. He came specifically for it. But the problem with clinical trials is there are very stringent measures, for a good reason, to make sure that everything is done in standard fashion. And one of those procedures is you have to have a washout period of 4 weeks, which he could not afford. We put him in the hospital to try to monitor. He lasted 48 hours, had to go back on lenvatinib. So we ultimately were able to get a single patient protocol for him for access to the drug off of the normal national clinical trial, just with the FDA, just a protocol just for him. And within 1 month of being on selpercatinib off of lenvatinib, this is the healing that he had. So again, just highlighting an extreme case to show you that toxicity matters and can be the matter between life and death. So solution, pick a better target that's stronger, develop a cleaner drug. So I showed you all of those targets for lenvatinib. We call those dirty TKIs or promiscuous TKIs. So the more targets you have, the more side effects potentially you can have, which is why lenvatinib is a great drug, but has a lot of side effects to it and not always easy to tolerate. So what we have now, targeted therapy approved for treatment in patients with advanced thyroid cancer harboring different alterations of RET, medullary, including different RET mutations. I'm not talking about any patients or medullary thyroid cancer today. NTRK fusions, BRAF mutations, we've heard a lot about this already so far today. What's important is we have exceptional response rates with favorable toxicity profiles with these medicines. And it just highlights the need for molecular testing in all patients, and that was one of the driving factors for producing this consensus statement that I refer back to. So where do we go next? Statement number 5, NGS panels, including assays for gene fusions, are preferred given the ability to detect multiple mutations and fusions in just one assay. So this is next generation sequencing molecular panels that we send off on tissue. We could also do it on blood, but we prefer tissue. And then somatic mutational testing for RET, NTRK 1 and 3, and ALK gene fusions should also be performed on patients with advanced DTC. These are just two kind of back-to-back statements there. So what is it with RET? So efficacy of selpercatinib. I showed you one patient experience so far. So 70% of medullary thyroid cancer harbor RET mutations. There's RET fusion, solid tumors in thyroid cancer. We see this 10 to 20% of the time. It doesn't matter what the fusion partner is. We can use selpercatinib. There's also another drug, pralsetinib. It's very potent and highly selective. Here are the initial responses. Complete responses were seen in some. Does that mean the patient is cured? No, I would say no. Miracles do happen. There's always outliers, but complete response on imaging does not mean that it's every single microscopic cancer cell is out of a patient's body. I don't think you'll ever hear an oncologist say that that is the case. Most are partial responses. You can see the waterfall plots there, excellent. But here is the coup de grace, the toxicity, very favorable. Yeah, there's big numbers here, 28%, 94%, any grade of any adverse event. Again, we're going fishing for toxicities when patients are on clinical trials. Importantly, treatment discontinuation, only 2%. Standard of care patients for lenvatinib, probably at least 50%, at least want to take a break at some point. So this is very different. This is another case, another poignant patient of mine. I remember this because this patient was admitted. She was on lenvatinib for about 7 or 8 months, papillary thyroid cancer. Didn't respond. It had stable disease, so we knew that her disease was going to progress at some point, and it did very, very rapidly. These were her scans March 20-something of 2020, if you remember what was going on at that time in the world. She rolled into the hospital, and immediately everybody right into the ICU, high-flow oxygen, everybody's saying COVID, COVID, COVID. I'm over here saying it's not COVID. This is her cancer. We need to get something done. She also had a RET fusion protein. The study had just closed. So again, we were trying to get a single patient protocol for her. We were able to do it. We got the pills. We hand carried them over to the ICU. I remember also I was like pregnant out to here, and everybody was like trying to stop me because of COVID. And it's like, no, I want to make sure she swallows these pills. She did. I gave the ICU, I said, do not do anything. Give her a week to see if we can turn this around. And within 24 hours, she was out of the ICU, left the hospital a couple of days later on 2 liters of oxygen. This was her follow-up scan 3 weeks later. She didn't have a TAP. She had no pleural thoracentesis or anything. This was all the drug that was acting very, very quickly. NTRK is the same way. So there's a couple of different larotrectinib and entrectinib. Again, this is very rare, exceedingly rare in thyroid cancer. I have 3 patients with an NTRK fusion, none of whom require any systemic therapy yet. They just have a couple of thyroid nodules we've been watching now for a few years. So this just validates what we know. Treatment with RET inhibitors should be considered for patients who have RET-altered differentiated thyroid cancer. Same with NTRK. Again, just reinforcing the fact that if you find a mutation and you have a drug, you need to use it when you need it. BRAF, much more common. I quote my patients about 50% we will find a V600E mutation in there. Association between mutation and older age, poor clinical outcomes. We know this from earlier talks today. But what was absolutely phenomenal in the world of advanced thyroid cancer is the ability to have a drug that we can offer patients with a universally fatal and quickly fatal disease of anaplastic thyroid cancer. So this was published in JCO 6 years ago now. It was a phase 2 open-label trial of dabrafenib and trametinib. These are BRAF and MEK inhibitors. 16 patients with anaplastic thyroid cancer, and the overall response rate was nearly 70%. Again, those are response rates, so tumors that are actually shrinking down. Phenomenal results. Prior to this, we're quoting patients' overall survival median 3 months, 4 months. It's worse than GBM. It's worse than pancreatic adenocarcinoma. But now we have something to offer. Here's the waterfall plots, the swimmers plots. This was the updated efficacy and safety data a year or 2 after that initial report. This is unheard of numbers, unprecedented in anaplastic thyroid patients. So we need to use these medicines too. And if you look at statement 20 in particular, dabrafenib and trametinib combination therapy may be initiated for patients with resectable disease. We'll get to this in a moment. And should be promptly initiated for patients with unresectable ATC upon identifying this. And we need to do it quickly. The problem with all of this, and I mentioned this before, targeted therapies are not curative. Even if you get these great responses, and oftentimes with these very highly selective targeted therapies, we don't know how long they're going to last. Is it going to be 3 years like lenvatinib? Is it going to be longer than that? We don't know. But ultimately, just like bacteria do with antibiotics, they find ways to get around it, so too cancer finds these so-called escape mechanisms leading to drug resistance. And so we need to find We need to find those new escape mechanism mutations, and then we need to develop a new drug against that. That is ideal. I won't spend time on this. It's just the second generation of the RET inhibitor. We had this trial open. It has since closed. I was very enthusiastic about bringing it for my thyroid cancer patients, but a good problem to have is I couldn't accrue any of them to this study because all of them are still doing great on the first generation of selpercatinib. So we'll see. That's a good problem to have. We'll see how that times out. Again, with these patients, we're very enthusiastic about these targeted therapies, but I know that their timeline is limited. It's unlikely I'm going to have a patient who's on them for 20 years. My longest patient so far on selpercatinib is pushing 6 years. I have no idea when that's going to stop. And patients ultimately will succumb to disease unless we're able to develop more drugs to do that. So this is a patient, 60-year-old male, diagnosed with PTC a few years ago, had surgery, completion thyroidectomy. You can see the details here. I won't harp on that. Treated with RAI, had been following regularly every 3 to 6 months with his surgeon who's sitting in this room right now. Last appointment was in March. No concerns. He was completely doing well, asymptomatic, no problems. The neck ultrasound showed identical findings of what it always has. And then a few months after that, rapid onset vocal hoarseness and dysphagia. Got in with his ENT from his initial surgery, had some vocal cord stuff he would get injections and things for. Called him straight away, got in within a week or so, had a CT of the neck, and you see here. Necrotic appearing mass that was not there at all just 3 months prior. I think we all know where this is going. You can see a slice of the CT there on the left and the corresponding PET scan. It was actually more impressive on the CT scan as you scroll through it, but for visual purposes, the PET's always nice to throw up there. So he had a biopsy quickly, high-grade carcinoma consistent with anaplastic thyroid cancer. This is a nightmare. He's like 63, 64 at this time. So statement 4, rapid testing. It's not good enough just to test for it. We have to have rapid testing to assess BRAF mutational status, and it should be obtained for all patients with ATC. Even if we have that rapid test and it is positive, we still need to get complete mutational testing as well. So this is his history again, and we did. Within 24 hours, we knew that he had BRAF mutant ATC. We went ahead and got this, and it came back 2-3 weeks after I already started him on targeted therapy, dabrafenib and trimetinib. And really, this case just highlights the fact that this is all multidisciplinary. What's interesting is it's not uncommon that if a patient shows up de novo with anaplastic thyroid cancer and they're having issues that land them in the hospital, and they don't have an endocrine surgeon or a surgeon or an endocrinologist who's been following them for their history for years and years and years. It will often be the pathology department who sends an email or sends a page. Hey, it's almost like they're sniffing around. Hey, there's an anaplastic patient. We just got the path. We're running BRAF now. It should be out by end of today or early tomorrow. So before anybody else knows, it's pathology who's contacting me or my colleagues to kind of get the ball rolling. I also have to say, our support with pharmaceutical companies for some of these drugs. So our pharmacy at Taussig has an emergency supply for a lot, not all, but a lot of these, and BRAF targeting drugs are one of them. So now it is standard practice that I know that I'm walking in to see an anaplastic thyroid patient. I know that they have a BRAF mutation, and I get to walk in with a little brown bag that has their pills to hand right to them. So for those who don't know, when we order things like lenvatinib or sorafenib or selpercatinib, it goes through a specialty pharmacy, clearing the patient's insurance. It usually takes 7 to 10 days for them to have drug in hand. These are patients, we have a supply. If we know it, we identify it, we walk in, I meet them. They've already Googled what anaplastic thyroid cancer is, and it's a bad thing. And then I walk in and tell them, here are the pills that you need to take, and you need to take them like right now. So that brings us to, and I'll just wrap up here as quickly as possible. We do have a neoadjuvant study. It's actually going to close pretty soon because it's been a multi-institutional effort. This is led at MD Anderson, but we have it open. A couple of other places have it open. And the beauty of this study, because this is a very busy slide, but the beauty of this study is adding BRAF targeting drugs with immunotherapy, which I never talk about immunotherapy with thyroid cancer because it's not approved. It's only within a clinical trial. But the beauty of this trial and how it's designed is you want to start patients on drug before they get on trial. Usually with a clinical trial, as I mentioned with the previous patients, there's washout period, there's this, that, and the other, and it usually takes a good few weeks to get a patient actual treatment on a clinical trial. Not with this. The idea is that you get that drug, you get that in, and then you can enroll them onto this study and add the pembrolizumab immunotherapy, and it's true neoadjuvant because they have to go to the operating room. So this is where the patient started. 6 weeks later, this is what he had. He went to surgery 6 weeks after that for resection, had sentinel selective left neck dissection, level 6 and 7, and what pathology showed was PTC, which is always interesting. So we've had 4 patients on this study. All the anaplastic essentially is gone at the time of surgery, but the PTC component is still remaining, likely representing ATC. So just to kind of update everybody here, he finished adjuvant radiation. Part 2 of this, you can get radiation, you can hold radiation, you can continue drug, you can continue immunotherapy. It's kind of like dealer's choice. We continued him on everything. I'll see him in a couple of weeks with another PET. He's had imaging since, and he is so far, knock on wood, no evidence of disease, which is completely unheard of for anaplastic thyroid cancer. So key takeaway points today. I know we rushed through a lot of material, but our current landscape is molecular testing is standard of care in all patients with advanced thyroid cancer, all patients. Targeted therapies are approved in the incurable recurrent metastatic setting, but we need to do better of, number 1, identifying escape mutations and the subsequent drug development there. And then we need more clinical investigation. How do we use these selective therapies in the neoadjuvant setting? Can we identify a RET fusion sooner and do a better surgery, or prevent micrometastatic disease distantly from becoming clinically apparent? So those are my main key takeaway points, but I just want to end on the very first statement of the mutational testing guideline document, which is the optimal care of these patients is best delivered by not one person, but a multidisciplinary team, including endocrinologists, medical oncologists, surgeons, pathologists, radiologists, radiation oncologists. None of us is able to do it by ourselves, and all of us should be involved in the care of these patients. Thank you.
Thank you. Sure.
Yeah.
So I may have missed this, and I apologize if I do, because I missed the beginning, but are there guidelines as to how often you should repeat molecular testing on tissue to see how the mutation is changing and how you may have...
Right. So the question is, do we do repeat molecular testing? How often? What are the guidelines on that? There's no formal guidelines on that. I anticipate there will be at some point. I know it's our practice. If something doesn't make sense, and we kind of extrapolate from the lung cancer data, because they do this all the time, right? So they have a lot of disease. If everything is responding nicely, but you get a scan and there's something weird that's growing, ideally you want to biopsy that, and as long as you're biopsying and you have the tissue, send it off to see what's happening. That's how we're going to identify what these escape mechanisms are. When we had the second generation LOXO study open, we were doing that a lot more frequently because we were looking specifically for the mutations that were required to be eligible to go on that study. I anticipate we'll be doing that more and more. I've done that as standard for a few of my patients who have progressed. Nothing new or different has come about, but at least in the cancer center over the last 6 to 9 months, we have our cancer center director is really focused on novel therapeutics clinic and a phase 1 clinic, and so that requires updated molecular testing across the board. And so I'm often doing that, especially for younger, healthier patients where I just don't have anything to offer them. I'm looking for anything. Yes.
Thank you for that presentation. Quick question for the case you're describing where the final pathology was PTC again. Is that just because of initial clonal divergence, where then the treatment only kills the anaplastic cancer, but the papillary thyroid carcinoma was not impacted? Or
Yep. We think so. So So the question is to repeat for the case that I presented with anaplastic thyroid cancer where upon surgical pathology the PTC portion still remained. We've actually seen that in all 4 patients that we accrued to this study, at least 3 out of the 4 off the top of my head. And that's just because these drugs just don't work as well on the papillary thyroid component. Even though we use them for PTC that's BRAF mutant and we can have really good results, it's not like it is in anaplastic where it really is just 100% driving that cancer.
Thank you.
Thank you.